Hi, good day, everyone. I'm Simon Tsang from the Department of Surgery at the University of Hong Kong, and I'm honored to be invited to to share my experience regarding the use of high-intensity focused ultrasound for treatment of liver tumors in difficult locations. First of all, I have nothing to declare in terms of conflict of interest, and just a little bit of background regarding the treatment options, because in fact, in our locality, hepatocellular carcinoma is one of the commonest cancers, one of the commonest primary cancers we encounter in our practice. But unfortunately, up to 75% of these patients are not suitable for liver resection for various reasons. And the most common reason for unresectability is the presence of cirrhosis. And so the treatment options are rather limited. And they include, in the presence of mild cirrhosis like child pugh A disease, then a limited resection such as a wedge resection or a segmentectomy may be performed. But in certain cases where resection is deemed to be dangerous or too invasive, or the liver's too cirrhotic because of poor indocyanine green retention tests or the degree of portal hypertension, then we may actually opt for radiofrequency ablation or microwave ablation of these local tumors if they're small enough, like less than 3 centimeters in size. Other tumors may be treated by stereotactic radiation therapy, and multifocal disease may be used to treat, may be amenable to transarterial chemoembolization. And there's also the option of liver transplantation in selected cases if they fulfill the UCSF criteria. But unfortunately, in our locality, because of the scarcity of liver grafts, that is not often the case. And we may just have to opt for ablation in some of these for local disease. And some patients with systemic disease may need systemic therapy as well. And Highfoot has its use because it is non-invasive. It is a transcutaneous treatment, and it is well tolerated by patients. I'm not going to go into the basics of Highfoot because that's not part of this talk. But what we have to understand here is that Highfoot can be offered if the liver tumor, if it's solitary, if it's less than 5 centimeters in size, it may be suitable. And we only offer Highfoot if there is unresectable disease, or if we consider after multidisciplinary meeting that radiofrequency ablation or microwave ablation is not feasible. And in fact, if there is ascites, then radiofrequency ablation may not be the best treatment because of the risk of bleeding, and also there's a risk of liver decompensation as well. Whereas in Highfoot, we have shown that the presence of ascites is not a contraindication. And we can even perform Highfoot ablation in the presence of advanced cirrhosis in patients with child B or child C cirrhosis, as long as there is no evidence of hepatic encephalopathy. And because this is a transcutaneous treatment without any wounds, then the recovery is very quick. The majority of our patients, in fact, over 90% of our patients can go home the following day. And we, for tumors that are smaller than 3 centimeters, we have shown that the complete ablation rate may be up to 68% after one session of treatment with Highfoot. But then there are certain contraindications for Highfoot against HCC. This procedure has to be done with breath holding and it has to be done under general anesthesia. So if the patient is medically unfit for general anesthesia, then we should not offer Highfoot. And if there's any evidence of major vascular invasion, such as main portal vein or side branch portal vein invasion of the tumor, then we should not give Highfoot. If there's evidence of extrahepatic disease or direct invasion into the surrounding organs, like invasion into the colon, invasion into the gallbladder, then Highfoot is contraindicated. And last and not least, if we cannot see the tumor with ultrasound, because our system is ultrasound based, if we cannot see the tumor, then we cannot treat it because that's the physics involved. If the sound waves cannot get to the tumor by localization, then we cannot treat it. And most and foremost, the patient's skin condition has to be satisfactory as well. And this is a system we use, which is the JC system from Chongqing Highfoot Technology Company. And we've been using this very reliable workhorse for over 10 years. And it served us very well. And it's benefited hundreds of patients in our center. And the patient is typically treated under general anesthesia for ablation of liver tumors. And it comprises of a console, which is a control console. There's an imaging system with ultrasound, real-time ultrasound guidance in a water bath, and the patient lies either on the prone position or in the right lateral position for ablation with a treatment transducer, which is embedded inside the system here. And so, unfortunately, because this is a transcutaneous ultrasound-guided ablation system, then there are difficult locations. Some parts of the tumor, when they're located in the dome of the liver, for example, in the dome of segment 8 or segment 7, the liver dome is actually surrounded by the diaphragm, lung around it, surrounded by rib cage and front and to the sides as well. So you can't see it very well. And there's also a risk of other locations may sustain thermal injury if we're not careful. For example, if the tumor is located in the dome of the liver on the left liver, such as a left lateral section, if you're not careful, you may actually injure the heart because the ultrasound energy travels, and as it traverses the surrounding tissues, it may cause injury to the surrounding collateral structures, such as the heart, or if you're close to the bile ducts, it may actually cause biliary duct injury, resulting in biloma or liver abscess. You may injure major blood vessels, risk of injury to hollow organs, such as to the gallbladder, to the stomach, the duodenum, or the bowel, such as the colon as well. And I'm going to show you a few cases here. Whenever we do Highfoot ablation, we always make sure that prior to the procedure under general anesthesia, we have to make sure that we can actually see the tumor. So we always have axial imaging, such as a CT scan or MRI available to us, and we review the image. And here we can see that there's a tumor situated in segment 7 of the liver, close to the dome, situated pretty high up. As you can see here, it's surrounded by lung tissue, surrounded by a little bit of ascites, a very cirrhotic liver. And imagine that if you're going to do a transcutaneous ultrasound, it's going to be rather difficult if you do it from the side, from the abdominal wall, from the chest wall. But whereas if you do it in the lower position, if you do it subhepatically, if you place a probe and pointing it towards the head, pointing it cephalad and angulating it, then you easily visualize the dome, even in the presence of air around the dome, because you're actually looking from down upwards. You're looking up towards the head of the patient, towards the right shoulder. And so you're going to be able to visualize the tumor. So, okay, we're happy with that. We're going to anesthetize the patient. We place the patient on the machine, and we also ensure that we can actually visualize it using the ultrasound transducer in the Highfoot JC system machine. Placed in the right lateral position. And here you can actually tilt and angulate the transducer towards the head end. To the right side of this video is the head end, left side is the foot. And here we're actually using the motor to tilt it towards the head. And you can see it's tilting, and you're going to be able to visualize lesions close to the dome of the liver. As you can see here in the schematic diagram down below, you're tilting it towards the head direction, so you're going to be able to see it. But unfortunately, it's still surrounded by diaphragm. You can't see it very clearly. There's a bit of air around it because there's lung tissue close to the tumor in the diaphragm. So this is not satisfactory because Highfoot, the energy that is used to ablate, does not travel very well through air. And so in order to make a good acoustic medium, we have to find something else. And therefore, we first of all have to localize the tumor. So we use transcutaneous ultrasound to mark the spot where we can actually visualize the tumor, where we're going to place the transducer. We degas and degrease the skin, place the patient under general anesthesia, under total intravenous anesthesia with mechanical ventilation, and we use artificial right pleural effusion. I'm sure some of you may be familiar with this procedure, and this is to allow for safe and clear visualization of the structures around the dome of the liver. And that would allow for the lung tissue on the right side to be displaced, and that would allow you to visualize the entire diaphragm and seeing the entire dome of the liver very clearly, as you can see here. And the technique is done by under an aseptic technique. The patient is first anesthetized, We place the patient in the Valsalva maneuver and stop the ventilator. And then we prep the skin with antiseptic and place a 16-gauge 2A epidural needle into the right fourth intercostal space along the mid-axillary line. And where we locate the pleural space by a loss resistance technique. If we get a smooth column of fluid entering the pleural space, then it's going to be very smooth, unrestricted flow of normal saline. And we typically infuse between 600 and 800 milliliters of warm normal saline into the pleural space. And following that, we place the patient back into the right lateral position and get this kind of image here. And as you can see here, the entire dome of the liver is very clearly visualized. The P is a pleural space, the R is a rib, but between the ribs, you can see the entire dome of the liver very clearly. And here's the tumor with the red arrow next to it. Next, we do the sonication. We do intermittent breath holds during sonication. And following artificial right pleural effusion, we can see here, we do not see any lung tissue at all. We can see the tumor very clearly. We can see the entire diaphragm very clearly, and we can sonicate. We can achieve complete ablation of up to 68% of cases if the tumor measures less than 3 centimeters across. And these patients actually make a very good recovery after the procedure. They are typically extubated, sent back to our usual surgical ward, and we do not routinely drain the pleural effusion. We allow it to be absorbed. And there's a very small pneumothorax risk of around 2%. And we typically just do serial chest radiographs, first of all, in the a few hours after the procedure, and then on a daily basis. And as long as the patient is asymptomatic, we let them go home. And the median length of stay in our patients is around 1 day. There's an extremely rare late complication of diaphragmatic injury, but that only happens a few years afterwards. And that's probably due to delayed diaphragmatic rupture, but that was only one case of that. And never have we seen patients who require surgery to treat their complication. And these patients have a procedure which is extremely well tolerated, even in the case of advanced cirrhosis. Secondly, I'd like to talk about what to do if there is a tumor which is close to vascular structures or portal pedicles, because there's always a worry about injury to the portal pedicles or to the veins around and to the bile ducts as well, because there's a dreaded complication of a biloma afterwards. And here we have a patient who had a 2.5 centimeter hepatocellular carcinoma situated in segment 7 of the liver, as you can see here, and we performed Highfoot. In fact, what we see here, after 1 month after Highfoot ablation, we did this MRI scan with contrast, and here the tumor is completely ablated. There is no further enhancement in the arterial phase, and in DWI, there is actually no signal at all. And here you can see that the if you look very closely, you're going to see that the right hepatic vein is completely spared, it's still patent, whereas this tumor was exactly abutting against the right hepatic vein. But fortunately, there was no evidence of an invasion into the main trunk of the right hepatic vein, and there's no evidence of any inferior vena cava tumor thrombus. And so this patient had complete ablation, despite the tumor being right next to the right hepatic vein. And we have been shown, in fact, animal studies and also in vivo studies by Professor Zhou and from Dr. Orsi from Italy have shown that even if the tumor is abutting a major hepatic vein, complete ablation is safe, as long as the tumor is not invading into the hepatic vein. But of course, because of the high flow inside the hepatic vein, we have to be aware of possible incomplete ablation because of the heat sinking effect, which may actually reduce the efficacy of the temperature rise during sonication. So we have to make an allowance to that. But we have to be aware that a portal pedicle is a completely different story, because here we have a tumor which is in a very cirrhotic liver. There is ascites. In fact, the patient underwent transarterial chemoembolization prior to this Highfoot. And this tumor is actually close to, but not invaded into the right posterior portal pedicle as shown here. And because there is a few millimeters distance between the main trunk of the portal pedicle and the tumor, and because this tumor is actually in the periphery of the liver, then we can still safely do sonication by Highfoot and ablate this. But we have to take extra care, because if we're not careful, if we injure the portal pedicle, the patient may develop liver decompensation, liver abscess, and biliomas. And we definitely think that it is safe if we do it, if the tumor is situated 5 millimeters or more away from a pedicle or a bile duct. Likewise, we have to make sure that we reduce the power of ablation when we run close to the pedicle. So the usual principles of ablating from deep to superficial has to be done, but we have to be careful that we do not go too deep. Otherwise, we're going to hit the pedicle. Next, here's the 1 centimeter tumor in the segment 4 and 8 of the liver, which is actually, my colleague called me because he said that it's rather close to the heart. And in fact, it's, this is on the diagram on the left is the handheld ultrasound probe, and it's rather close to, but it's still about 3 centimeters from the heart. So we decided that it is still safe. And as you can see here, the patient has a bit of ascites as well. So visualization is extremely good, and good Highfoot can be done. But we have to be careful, making sure that we take the usual precautions regarding tilting the probe, making sure that we can see the tumor very clearly. We don't go through any of the ribs. We don't want to risk a skin burn. We don't want to go too deep and hit the heart. We've never had a cardiac injury in our case series of over 500 cases of Highfoot, luckily. And as we can see here, Highfoot is extremely precise. And next, I'd like to show you a little video about this lady who is quite cirrhotic with portal hypertension secondary to cirrhosis and non-alcoholic steatohepatitis, with a large sizable tumor occupying the left lateral section of the liver. Because of the presence of portal hypertension, we decided that she's not a candidate for surgery. And because of the size of the tumor and because of her underlying condition, we decided that Highfoot would be best for her. And that's her choice as well to undergo this treatment. But as you can see here, it is rather close to the stomach. It's rather close to the surrounding vascular structures. So we just have to make the usual precautions. But on the Highfoot screening, we could not see the tumor very clearly because of the surrounding fatty liver. So we decided that we had to alter the ultrasound properties of the tumor. And so we decided to perform a transarterial chemoembolization first. And by doing highly selective highly selective angiography of the left hepatic artery, we're able to see get a very good blush from the highly vascular HCC in the left lateral section. And we use an iodized oil emulsion plus cisplatin to embolize this. And we're able to get a very good view on subsequent Highfoot 2 weeks later. And we got a very good ablation. But because this is situated in the left liver, it's rather close to the stomach. So we had to make sure that the patient's adequately fasted. We gave the patients a fleet enema and enema as well to make sure that the colon is not grossly distended. We insert a nasogastric tube in order to decompress the stomach to reduce the risk of gastric injury. We place the patient in the prone position. And as usual, we place the probe slightly down in order to angulate the probe to upwards so that we do not hit any of the mediastinal structures such as the heart. And we're able to completely ablate this tumor after using up around 741,000 joules over a period of around 2.5 hours. This is the aftermath. The patient had previous cholecystectomy. As you can see the scar here, there's some erythema from the local ablation by Highfoot. But after application of ice packs overnight, the patient's skin condition was completely fine the following day, and she went home 1 day later. And the treatment was successful. As you can see here, I placed an X. The X appears to be higher up. In fact, we placed the transducer a little bit lower down than the X, and then we pointed the transducer more cephalad so that it pointed upwards towards the patient's from down towards the patient's diaphragm in order to avoid hitting the mediastinal structures such as the heart. And the patient made a very good recovery without any complication. And here, lastly, I'm going to show you just ablation, a video of a small tumor in the subcapsular posterior inferior segment 3 of the liver. Yeah, we have to be careful. A nasogastric tube was inserted in order to decompress the stomach. As you can see here, there's probably this hyper-echoic area is actually the stomach and the surrounding omentum, but we can still do a safe ablation of a subcapsular tumor, even if it's close. We do not do ablation if it's invaded into the stomach or invaded into a hollow viscus, but we can still ablate if it's close to it, as long as we control the power. As you can see here, there's satisfactory grayscale change. And so in summary, ladies and gentlemen, there are certain tips and tricks regarding Highfoot for liver tumors in difficult locations. First of all, we have to make sure that we angulate the transducer. We place it a little bit lower down, but angulated Keffer-lat, so that we're looking into the liver from down towards the diaphragm rather than through the chest wall. And secondly, for right liver tumors, artificial pleural effusion is extremely useful in order to visualize tumor lesions in the dome of the liver. If we can't see the tumor lesion very clearly, we can use TACE and then do Highfoot a couple of weeks later. And we can assure you that it's safe to ablate when the tumor is abutting a hepatic vein, but we have to make sure that we have at least 5 millimeters distance from portal pedicles or the hollow viscera or from the heart. And so this is a recent review article I wrote in the International Journal of Hypothermia, which I hope that I can share some of my experience with my colleagues, all these esteemed colleagues worldwide. And this is our hospital. This is a view from our wards, and this is our young team. And thank you very much, Chairman.